Hello, and thank you for joining our November webinar. My name is Ellen Johnston, Program Manager of Risk and Coding Accuracy at Mount Carmel Health Partners, and I will be your host for today's webinar. We are excited to dive into this month's topic, misdiagnosing acute conditions in the outpatient setting, but first I'd like to cover some details. Health Partners is providing a small incentive for your time and attention today. In order to receive your payment, we ask that you watch this presentation in its entirety by January 22nd, 2021, fill out the webinar attestation and W-9, and return to Health Partners no later than January 22nd. If you have questions throughout today's presentation, please feel free to contact myself or Dr. Bennett through our contact information listed at the end of the presentation. Now let's get started. Our webinar topic today is focused on misdiagnosing acute conditions in the outpatient setting. Our featured speaker today will be Dr. Paul Bennett. Dr. Bennett is a physician liaison with Health Partners and board certified in family medicine. He retired from his practice in Grove City in 2018 after 12 years. Prior to that, he was a primary care physician in Southern California for 24 years. He was in practice with a strong managed care focus with risk contracts. Welcome, Dr. Bennett.
Thank you, Ellen. It's a pleasure to be here to discuss this topic with you today. Before we start discussing today's topic, let's review some of the risk adjustment essentials. Feel free to fast forward the video presentation if you feel competent in your basic risk adjustment knowledge. Risk adjustment is the methodology by which CMS determines how to adequately allocate resources to Medicare Advantage plans for patient care. There are many factors that determine resource allocation, both demographic and clinical. Demographic examples include age, patient gender, institutional status, Medicaid status, reason for being on Medicare eligible. Clinical factors include chronic conditions and diagnoses that have been shown in CMS data to require more resources. As you know, there are approximately 70,000 diagnosis codes included in ICD-10-CM. Every year, each code is evaluated using CMS data to determine which codes utilize the most resources. Once this is done, the data is normalized so that the average Medicare Advantage patient has a risk score of 1.0. Around 9,500 diagnostic codes are determined to affect risk, and they each map to what is called a hierarchical condition category, or an HCC. An HCC is a group of chronic condition diagnoses that are clinically similar and have been determined to have a similar effect on resource utilization. Each HCC has a weight, and these weights are what calculate the clinical portion of the patient's risk score. There are 86 HCCs that are included in the 2020 risk adjustment model. For a diagnosis code to be captured on the claim, it must have supporting documentation within the record. An easy way to remember documentation requirements is the acronym MEET, which stands for Monitor, Evaluate, Assess, and Treat. Only one of these elements needs to be present for each diagnosis that is taken into medical decision-making during the visit. As telehealth is becoming more frequently used with Medicare Advantage population due to COVID-19, it is important to note which modes of telehealth communication are acceptable for risk adjustment and closing HCC gaps. In order for telehealth visit to be eligible for risk adjustment, the visit must take place with real-time audio and video capabilities by an approved provider for risk adjustment, such as an MD, DO, PA, or CNP. Most importantly, must be documented in the medical record that the visit was completed over telehealth with synchronous or real-time audio and video services used. Documenting this and the time of the visit in the medical record will help to keep the visit compliant with CMS when capturing and closing HCC gaps throughout the year. Next, we will jump into information specific to acute conditions. According to the 2020 ICD-10 guidelines, medical professionals should code for all documented conditions that exist at the time of the visit that affect patient care or treatment. Do not code for conditions that were previously treated and no longer exist. Instead, historical codes should be used, especially if the condition would still have an impact on the patient's health. We will dive further into historical codes in the next few slides. Using medical data, we put together a table of the diagnosis codes most commonly miscoded. These codes that primarily should be used in a hospital setting and are unlikely to be appropriate in the outpatient setting. At the top of the list, we have unspecified cerebral infarction, followed by non-ST elevation myocardial infarction, and non-traumatic intracranial hemorrhage, unspecified. It is, in most cases, when a stroke is chosen, it is not actively happening in the office. Instead of choosing an acute stroke code, a historical code should be chosen instead. Physicians should also code for any long-term effects the patient might be experiencing from their stroke, such as difficulties with speech and language, hemiplegia, or monoplasia. Down below are a few examples of codes that can be used. The first is the basic historical code for a TIA without any residual effects. The second code is what would be used if the patient was experiencing long-term difficulties. The last few digits of this code are for the physician to specify which deficits the patient is experiencing. For example, speech and language deficits, or hemiplegia, or paresis. As we have said in the past, the physician should code to the highest level of specificity. When a patient presents with deep vein thrombosis or pulmonary embolism, it is important to document whether the condition is acute, chronic, or historic, the vein or laterality if known, and if the patient is taking prescribed or is prescribed any anticoagulant medications. Below is a small guide that shows what codes could be used to specify the status of either a DVT or a PE. Also, the historical codes are listed for resolved PE or DVT. When considering if an MI should be coded, documented as historical or active, use this graph as an aid. If the MI is less than 4 weeks old, it should be treated as active. But if more than 4 weeks old, it should be coded as historical or old. The 4-week cutoff is specified in the ICD-10 coding guidelines. It is important to properly document and code whether the patient's cancer is ongoing or in remission to better represent the patient's burden of illness. Primary malignant neoplasm should be coded as active when the patient is actively receiving treatment or being managed. This active code should be used until there is no further treatment required, or if the patient is not in remission but has opted out of treatment. The code category Z85 series, personal history of malignant neoplasm, is to be used when the patient is no longer receiving any treatment and the neoplasm has been eradicated. There are certain permanent conditions that should be documented and coded annually to properly reflect the patient's burden of illness. These are generally referred to as status codes. Common status codes include artificial openings, BMI range, amputations, insulin use, dialysis dependence, and transplant status. This slide lists the most commonly used status codes in the outpatient setting. For example, Z89.411, amputation of the right great toe, can, as we know, severely impact the continuing risk that the patient faces in the future. Ellen will now review a few examples that demonstrate the content covered today.
Thank you, Dr. Bennett. Example 1 is a 72-year-old who was seen after experiencing a stroke a few weeks ago. She originally presented to the office with slurred speech and a right hand clumsiness and was directed to go to the ER. The patient's speech issues have resolved and her right-handed clumsiness is improving, although slight monoparesis is still present. A referral to PT was given. The correct diagnosis code in this scenario would be I-69.831, monoplegia of upper limb following other cerebrovascular disease affecting the right dominant side. For your information, the ICD-10 coding index does not distinguish between monoplegia and monoparesis. The second example is a 70-year-old female who was following up 6 weeks after experiencing a myocardial infarction. She has no residual effects from the MI, but she is still smoking cigarettes daily. She was advised to quit smoking and counseled on a healthy lifestyle, including moderate daily physical activity. The correct diagnosis codes in this scenario would be I-25.2, old myocardial infarction, since the MI is more than 4 weeks old, and F-17.210, nicotine dependence, cigarettes, uncomplicated. Our last example shows an 80-year-old male who presents for regular colostomy care. He had a left colectomy 5 years ago for treatment of his colon cancer. He currently follows his oncology yearly and has had no recurrence of the disease. The appropriate diagnosis codes for this scenario would be Z93.3, colostomy status to account for the patient's colostomy, and also Z85.038, personal history of malignant neoplasm of large intestine, since the patient's neoplasm is no longer receiving active treatment and has been eradicated.
We have 3 important takeaways from today's content. Number 1, resolved conditions. When a condition is resolved, note that the condition has resolved in the medical record and do not use an active diagnosis code for this condition. Personal history. When a condition has resolved but still affects the patient's burden of illness, it is appropriate to use a personal history diagnosis code. Annual status code capture. When a patient has one of the status conditions listed on slide 15, it's appropriate to document and capture these codes once in the calendar year, since they can affect a patient's burden of illness. This is our last webinar in the 2020 series. Be on the lookout for details on upcoming presentations for 2021. The sources used for this presentation are listed on the slide, and this is followed by our disclaimer encouraging you to use the ICD-10 coding guidelines yourself to assure accuracy. Thank you for attending and listening to our presentation today. Please return the attestation document and the W-9 included in the email to Ellen Johnson by Friday, January 22nd, 2021, if you're interested in the incentive. If you have any questions about the content, please feel free to reach out to any of the contacts listed on this slide. We hope you learned a little bit more about documenting and coding for acute conditions in the outpatient setting and are able to apply this knowledge to your everyday practice.